In Chapter 12, we'll be looking at mostly the different types of psychological disorders, from anxiety to mood disorders, dissociative disorders, and a few other categories. But it starts out talking about what is abnormal, and then we move into the classification, and we talk a little bit about the DSM-5. But first of all, what makes something abnormal? And as you look, you guys, you can see these three different criteria: deviant, maladaptive, personally distressful. Those three things separate behavior in terms of determining whether it's something that's acceptable or not. If those three individuals at the bottom, Alicia Keys, Hope Solo, Zuckerberg, they're non-typical or atypical, but they're not deviant. Deviant has to be culturally unacceptable. Those people are valued in our society, and you can throw in many other kind of well-known folks that do things that are extraordinary or outside of what is considered normal, but it's not deviant. We value it. We like to watch it. We reward it. Deviant would be culturally unacceptable. Some examples there. A woman who secretly makes herself vomit every meal may never be seen by others as deviant because they do not know about it. This is the pattern of behavior. It makes it feel shameful or guilty or depressing. But deviant would be definitely a criteria. Maladaptive interferes with effective functioning. Somebody who has to drink before they go to work, drink at lunch, and maintain a level of altered consciousness just to feel normal. It's maladaptive. Somebody who cannot stay throughout the duration of a lecture because they're worried about having an anxiety attack. That's maladaptive. It interferes with effective functioning. It interferes with things that you want to do in your life. Personally distressful. Yeah, this person is reporting feeling distressed. They're reporting having problems with getting out of bed and taking care of things that they need to. They're not happy with their life. Now, not all mental disorders or psychological disorders, there's not always a level of personal distressment on that person's part. There are some, specifically with personality disorders, where a person doesn't feel distressed and they're kind of like, this is who I am, and so, but most of them you'll find a level of personal distressment. The different theoretical approaches, we've got the biological approach, number one, and this looks at things from a brain perspective. Medical model is at the heart of it, describes psychological disorders as medical diseases, medical illnesses of patients treated by doctors. But we look at the brain, genetic factors, and neurotransmitter functioning. Is there a good balance there with neurotransmitter, or is there an imbalance or deficiency in one of those neurotransmitters? The psychological approach, emphasizes contributions of experiences, thoughts, emotions, and personality. And as it says there, psychologists might focus, for example, on the influence of childhood experiences, personality traits, learning experiences, or cognitions in the development or cause of psychological disorders. The sociocultural approach, which is important today, it wasn't back in Freud's day or some of the early pioneers. Now we put an emphasis on cultural influences in the way we try to understand something. That example over on the right, Wendigo, is something that's culturally related, y'all. We don't see it as we see it as a part of somebody's religion or their spiritual belief system or what have you. So we got to be careful in assuming that something is a psychological disorder when it might be related to a person's belief system that has to do with their culture or comes from their religion. I know people that believe they hear from God, but they don't meet criteria for a psychological disorder by any means. It's just a part of their spirituality. It's a part of their religious belief system. Biopsychosocial approach, unique contributions or combinations, rather, the biological, psychological, and sociocultural factors. So it sort of pulls them all in together. And most people approach things today in a clinical setting. We look at the biopsychosocial approach. In fact, intakes that we do in clinical settings usually have a biopsychosocial component to it. We pull from the person's history, their medical history. We want all the medical history records. We want to know about current psychological functioning, recent psychological functioning, history of relatives' psychological functioning, also sociocultural aspects. What are some of the things in regards to your family system or your relatives or the culture that you grew up in, and how does that inform your current psychological state. So all those things factor in. We don't want to simplify it down to one approach or another. It's really good to kind of pull from all of them. Classification systems, common basis for communicating. The reason we classify, the reason we put psychological disorders into different categories are these reasons here. It does help us communicate. It says if one psychologist says that a client is experiencing depression, another psychologist understands that a particular pattern of abnormal behavior has led to this diagnosis. In studying the DSM, which we'll get to in a minute, you can understand that better. It allows for, I think, professionals in different areas of psychology, in different areas of clinical psychology, to understand the language that's being used. We speak a DSM language where we don't have to, I guess, clarify some of what we're saying at times for us to be understood by other people that work in the field. Can help make predictions. Yeah, it can. It says classification system can also help clinicians predict how likely it is that a particular disorder will occur, which individuals are more susceptible to it, how the disorder progresses, and what the prognosis or outcome is or will be. May benefit persons suffering from symptoms. Sometimes having a diagnosis can help. It helps me give a name. It helps me come up with options for treatment. I can study it on my own that way. For other people, they really don't want a name. They just want help. They want to be treated. And we can treat psychological disorders without having to diagnose them first. We can treat the symptoms and arrive at a diagnosis later on if need be. May also create stigma. That's one of the problems, I think, and a lot of us have an issue with this. I do too. I don't like labeling. I don't like stigmatizing, and this sometimes can have an effect. Some people don't like having that on their medical history, or don't like being referred to as having a psychological disorder. And it also can cause people to sometimes act out symptoms or fall back on it or use it as a crutch. And we don't want to see that happening either. So there's a lot of issues with stigma. The DSM-5, Diagnostic and Statistical Manual of Mental Disorders 5, is the book that we use here in the U.S. We'll talk a little bit about the DSM here. It says in 1952, the American Psychiatric Association, the APA, published the first major classification called the Diagnostic and Statistical Manual of Mental Disorders. That's the current DSM-5 that you see the picture of here. It was improved in 2013. This edition of the DSM is the product of a 14-year revision process. The DSM-5 differs in many ways. Yeah, it's actually a lot different than the DSM-4, and there were some big changes that were made. Some of that controversial. Some people don't like the new DSM-5. They don't like some of the changes that were made, and so it kind of depends on who you ask within the field of psychology about these changes that were made. And people are still getting used to the DSM-5, even though it's been a couple years now. We're still adapting. In fact, some of the continued education classes or hours that I have to receive to maintain my license require me to get DSM-5 work every couple of years to do some training in DSM-5 these last 2 years, 3-year period. Some of the critiques: treatment of the psychological disorders as a medical illnesses takes a biological view of disorders that have roots in social experiences, does not equally emphasize strengths and weaknesses that might help destigmatize psychological disorders. And listen, this is a diagnosing book, you guys. It has no treatment in it. It doesn't offer any treatment ideas. It really is just helping understand the etiology of the disorder, kind of where it first was established. And then also does make some predictions in terms of what could transpire in having this disorder for a certain amount of time. But it's not a book of treatment. It's really just for diagnosing purposes. Some of the other things: relies too much on social norms and subjective judgments. Listen, we have no blood test to diagnose in the field of psychology, right? In clinical psychology. We have to rely on what people tell us about their symptoms. And then we use the DSM to look through and see what criteria. The DSM basically has different criteria that you have to meet for each diagnosis. And if they meet 4 out of 5, for example, or if they meet 8 out of the 10, or whatever that might be, well, then we kind of go with that and we ask further questioning. But it really relies on the interactions with the clinician and the patient, and it needs. We're assuming we're getting forthright information from that patient, so you have to consider that. It's definitely somewhat of an art in a sense. It's not always a pure scientific process. It's not a pure scientific process, and that's one of the knocks on diagnosing using the DSM. Standards of some existing diagnoses have been loosened. Yeah, we'll talk about that a little bit too. It says some concerns is that the U.S. insurance companies generally require reimbursement by patients only for treatments that, for diagnoses that appear in the DSM. Very true. To get reimbursed, we have to provide a DSM diagnostic code, and you can't cram people into these codes. And sometimes some companies reimburse for these codes and not these other codes. It becomes a big problem when we're dealing with insurance. Another reason for concern is that part of the medical model is the assumption that disorders optimally are related, or are treated rather, through medical terms. Generally, that means prescribing medications, and medications are a type of biological treatment, which we'll talk about in Chapter 13, and they are very common. With the loosening of diagnostic criteria, many more individuals might be given powerful psychoactive drugs, perhaps unnecessarily. Thus, it is imperative that the DSM gets it right, and many critics argue that it falls short in the high-stakes context. Yes, these are issues. They are ongoing issues, and they can be quite a problem. I'm going to talk for a minute about anxiety disorders, and the things that it mentions here, the three things. Uncontrollable. Yeah, people really feel like there's not much they can do when anxiety comes over, when they're feeling anxious thoughts or they're having fears. It seems to be very difficult to put them in perspective or control them. A disproportionate to actual danger. Listen, most of this is not imminent danger. It's usually irrational fears. Fears that, if I really look at it commonsensically, it doesn't make sense to get this frustrated, this worried about something, and then disrupted the ordinary life. In order for them to be anxiety disorders, or for them to actually be a disorder, there needs to be some element of distressment and some interference with your life. The first main one is generalized anxiety disorder, persistent anxiety for at least 6 months. This is sort of a low-grade anxiety that's always there from the time you wake up to the time you go to bed. There's this feeling of uneasiness, or this feeling of scanning your horizon, or worrying constantly. You can still go to work, you can still go to school, you can still take care of things you need to take care of, because it's not that acute that it's that you're not allowed to go through the motions of life. However, it's there, and it's frustrating, and most people would say it's been there longer than 6 months. It's been there for years, if not, it goes way back in my history before they're actually diagnosed with this disorder. Panic disorder, recurrent sudden onsets of intense apprehension or terror. This comes on quickly, and it's a high level of anxiety. There's an acute level to it. And it says often occurs without warning and no specific cause. Sometimes we call them out of the blue panic attacks. Sometimes we can find a trigger to the panic attacks, and people can hit upon what's causing the panic attack. Other times they're out of the blue. We don't know. And so that person is left trying to figure out what is causing me to have this incredibly strong level of anxiety overcome me. I've known people that have gone to the ER on multiple occasions because they believe they're having cardiac arrest, because panic disorder, panic attacks can mimic cardiac arrest. They can mimic physical problems, and you experience them in a physical way. So as a result, sometimes you're not thinking psychological, you're thinking more something physically is wrong with me. So as a result, people might go to their cardiologist to get work done, just to give them reassurance it's not their heart, or it's not something physical. They do more blood work with their doctors just to rule out other things. In extreme cases, as you see the term down here, it can lead to agoraphobia. And agoraphobia is technically the fear of open spaces, y'all, but it's really the fear of having another panic attack. I retreat back to my home, and I don't leave my home because out there, outside of my home, and there's a chance I could have a panic attack, and that might leave me humiliated in front of other people, or without a way to escape, or just to avoid the sheer terror of it. I might spend a lot of time inside my home, or not leave at all. That's a serious condition, and especially you can think of in terms of disrupting your life. Some other information about panic disorder, and I'm not going to go through every aspect here. This all comes from your book, so you can read back over it. The amygdala